Cervical cancer is one of the most preventable cancers there is, literally the most preventable. They say that 99.8% of cervical cancer could be prevented. And unfortunately, in the UK, 3,200 women are diagnosed with cervical cancer every single year, and that's equivalent to 8 cases a day. And unfortunately, 850 women or people with a cervix die of cervical cancer every year, and that's equivalent to 2 people a day. So those are preventable deaths. Majority of the UK, this is what happens. The first thing they look out for is for the virus that we spoke about, known as HPV, the human papilloma virus, right? So they look for that in the sample, and if they don't find any HPV, okay, so if you follow me along, we go through the first arrow, no HPV is found. Then you go back to the routine recall, which, as I said, is between 3 to 5 years, depending on the age, okay? Now, if they find that you have HPV, so you have that virus, they then check to see if there are any abnormal cells, okay? Now, if they find that there are no abnormal cells, but you have HPV, you then go back to what's known as the 1-year recall. So they will ask you to come back in a year's time, where then they will check again to see if you still have HPV, because what happens is our bodies are really good, it can get rid of it. So we give you a year to get rid of it, and sometimes no HPV is found when you come back in a year's time, and we put you back to the routine recall every 3 to 5 years. However, sometimes after that 1-year recall, you may still have the HPV there. So we give you another chance, another year for your body to fight against it, right? To see whether or not it's gone. And if it goes away, again, you go back to the normal recall. However, if it persists and it's the 3rd time you've come, even though there are no cell changes at all, you go for what's known as colposcopy.
Hello and welcome to Afternoon Tea. I'm Dr. Linda, emergency medicine physician, and I'm here with my lovely co-host, Dr. Erica. If you haven't met before, please let us know where you're checking in from, hot cup of tea you're having today.
Hi everyone, I'm Erica. Did you know that 89% of deaths in the UK are caused by lifestyle-related chronic diseases? And as a society, we've come to view chronic diseases as the norm, but this doesn't have to be the case, and your genetics don't have to be your destiny. Linda and I both use lifestyle medicine and nutrition to help our patients combat chronic diseases, and Afternoon Tea with Docs was born out of our shared passion to empower everyone with these lifestyle and nutrition practices, our experiences, and also the knowledge of our expert speakers, so that everyone can live a long and fulfilling life. If you haven't met us before, you can connect with us on Instagram, Facebook, and watch the replays of our previous sessions on YouTube. And we are here for Afternoon Tea every Sunday at 5 p.m.
March is Women's Health Month in ATWD, and I've spoken about endometriosis last week with consultant gynecologist Dr. Neetu Bajikal. This will soon be available on YouTube as all of our other video sessions. Today we have Dr. Aziza Sesay join us in conversation about cervical cancer. Dr. Aziza Sesay is an NHS GP working in the UK. She's a big advocate for health education and promotion, so she started her platform, Talks with Dr. Sesay, to educate, enlighten, and empower you to with the knowledge about common medical conditions in order to prevent them or at least moderate their progression. She does this through free live educational sessions through Zoom, infographics, and short educational videos that you can find on her Instagram and YouTube channel. We stand firmly with Dr. Sesay when she says health is truly your wealth. Hello, Dr. Sesay. Thank you so much for joining us today for Afternoon Tea.
Hi, thank you so much for having me. I'm so excited to be here. I've ever since you started the platform, I'm like, oh, this is such a great platform, and it's so important that we discuss lifestyle changes because, like you say, it really is the difference between life and death.
Thank you so much for always supporting us and being live. Today, we have been waiting for the opportunity to speak to you for quite a while.
Thanks.
So today we're going to be talking about cervical cancer, and as an NHS GP, you know quite a bit about what it is and the screening process. And are you involved in the screening yourself?
So essentially, where we're involved is as a GP, every opportunity that we have, and we use this system called, well, I use this system called EMIS Web. We see whether or not patients have had their screening, and we opportunistically advise patients, oh, you've missed your cervical screening appointment, or you haven't had it yet, or you're due to have one. And we encourage them to have it, and we may have the discussion then as to why it's important for them to attend. So that's where GPs are often involved. We will speak to and encourage patients to have it done, but majority of the times, it's the nurses in clinic who perform the cervical screening procedure, and then we get the results and we look at it. And depending on the results, sometimes patients aren't quite sure what they mean. So again, we explain and hopefully give them some reassurance about what different results mean, but we'll discuss that later on.
And I believe you wanted to do a poll, didn't you? Let's see if I can bring the poll up.
Well, the results for the first question, is cervical cancer preventable? Well done, everyone. You all answered yes, and that is correct. And that's the whole point of this discussion. Cervical cancer is one of the most preventable cancers there is, literally the most preventable. They say that 99.8% of cervical cancer could be prevented. So that's a lot. And this is why these discussions are really important. Is the cervical screening test designed to diagnose or pick up cervical cancer? Now, this is almost a little bit like a trick question, because usually with screening, you think that it's done to pick up cancer, but actually the answer is no. It's not done to pick up cancer, cervical cancer. It's done to prevent it. So we're checking the health of the cervix, and we're also checking for a virus known as HPV, or human papillomavirus, but we'll elaborate on that in a minute. So those who answered no, you were right, and 40% of you answered no. And then the third question, do you attend your cervical screening regularly? This was a really important question because actually statistically, it does show, unfortunately, there's a high proportion of people who don't attend their cervical screening. In fact, 68% of people in the UK between the ages of 25 and 49 don't attend their cervical screening at all. And it was a bit less. So I think, yes, no, I beg your pardon, it was the other way around. Only 68.3% of people between the ages of 25 to 49 attend their cervical screening, and 75.3% of people between the ages of 60 to 64 attend their cervical screening. And in London, it's even worse. Only 46% attend their cervical screening. So looking at the answers in the poll, 60% of you said no. So we need to try and change that. And we're hoping, again, through this discussion, we'll be able to change the statistics and encourage more of you to attend your cervical screening, because it really does save lives.
Yeah, it's incredible to know that 99.8% of cervical cancers can be prevented. Absolutely shocking to think that if we brought the education to the people on a regular basis, that this is something we could stop even before it starts.
Absolutely. And unfortunately, in the UK, 3,200 women are diagnosed with cervical cancer every single year. And that's equivalent to 8 cases a day. And unfortunately, 850 women or people with a cervix die of cervical cancer every year. And that's equivalent to 2 people a day. So those are preventable deaths. Yeah, and this is something that we can prevent through a multitude of things, but the most significant one has been shown to be cervical screening. We'll chat about. But yeah, like you say, unfortunately, there are a number of people who don't attend, and there are numerous reasons as to why people don't attend. I don't know if anyone's written anything so far, Erica, but some of the reasons that I when I've done my research, you know, there are things of fear of the unknown. Some people have no idea what it will entail, and it sounds scary. It's like, what's a smear test? I don't want to do it, so they just don't attend. And then you have people who believe, well, if I'm well, why would I need to attend? Why would I go looking for trouble? What's the point? And then some people have their own individual health beliefs, like, well, it doesn't run in my family. I don't have any other illnesses. I don't have any symptoms. There's nothing wrong with me. Why should I attend? And then, you know, this is quite an intimate examination, isn't it? The screening test, how they do it, how it's performed. So some people are quite embarrassed, and so they don't attend because they don't want to go through that sort of intimate examination. And also, if they've had some sort of trauma in their lives, or if they've had an unpleasant experience in the past where they've had their screening done, they're less likely to reattend. If there's a language barrier, because we have so many different ethnic groups in this country, and if they get the letter in English and they don't speak English, how would they attend? They won't even know what they're attending for. And then there are problems with, for instance, we all have quite busy lives. How do we get the time to attend these appointments? Because you need to go in to get these things done. And when we talk about going in, access, some people, for instance, unfortunately, disabled women, 63% of them have been unable to attend their cervical screening appointment because of their disability. You know, so there's so many different factors involved, and I've probably not even spoken about every single one of them, but it's not surprising that, yeah, there are some reasons as to why people don't attend, and it's valid for them. So it's just trying to figure out a way that we can encourage more people and try and also make it more accessible to everybody.
Mm-hmm. And I guess also you talked about the fear of the unknown, not knowing what the screening test involves, but also some people are scared of what they might find on the screening, but actually 9 out of 10 results come back normal, and if it wasn't normal, what would that mean?
So basically what happens with regards to cervical screening, you get an invitation, so a letter in the post that your GP will send to you, as long as you're registered with a GP. So the most important thing is you need to be registered with a GP, okay? Otherwise, you're not going to get a letter. That's another reason why some people don't attend. They're not registered with a GP, so they don't realize. Clearly, okay. So women between the ages of 25 to 64 are invited to get their cervical screening done, okay? And between 25 and 49, you get invited every 5 years, and every 3 years, I beg your pardon, between 25 and 49, and every 5 years between the ages of 50 to 64, okay? So what happens is once you go in, the clinician will talk you through what the procedure will entail, and then they'll have you remove your clothes from your bottom down, basically, so no underwear, nothing. And they would often give you a sheet to cover your hip, basically to allow you to have your modesty intact, essentially. And then they perform the procedure, okay? So I actually have the equipment, and I wanted to show you the equipment as well. However, if any of you guys are squeamish and prefer not to see what it looks like, then just look away for the next couple of minutes. But essentially, what happens is when you're lying on the bed, the clinician will insert what's called a speculum, and this is what a speculum looks like, okay? So this is the regular size speculum. However, there are different sizes of speculum available, all right? This is a small speculum. I hope you guys can see, right? And for some women, they have a deeper cervix, so it's further down. So you would need a little bit bigger speculum. And this is This is what it looks like. I'm showing you both just to compare the size. So you can see this one is much longer than the regular size ones. And the reason that I'm telling you that there are different sizes available is just to make you aware, so that if you're scared or you're nervous and you feel like, oh, you want to try the smaller one first, you can mention it to the clinician. They can try that one first. And another thing to also say is that they also give you the opportunity to insert the speculum yourself if you're really, really nervous and you experience a lot of pain in the area, just so you are aware, okay? All right, so the clinician will then insert the speculum into the vagina, and it would go like this, right? And then she'll turn it this way. And then what she'll do is she'll open this bit up to visualize the cervix, right? And once she's seen it, she then locks this bit, so it's locked, right? And then she takes what's known as the brush. Now, if you can see, this brush has quite soft bristles, right? That bit is then inserted in through the speculum into the cervix and then rotated a few times so we can get enough sample, and then take it out. And then it's transferred into a sample pot, which is this, okay? So the sample pot has a bit of liquid in it, which helps to preserve the cells. And what happens is you basically shake this a few times, and then it's sent off to the lab. And within about 2 to 6 weeks, it may take a little bit longer now because of COVID, you get the results of your cervical smear. Now, talking about the results, which is where we're going to, I'm going to share the screen again. These are the things that can happen in the UK, okay? And this is what we test for at the moment in the UK, in Scotland, England, and Wales. In Ireland, Northern Ireland, sorry, they use an older technique. But the majority of the UK, this is what happens. The first thing they look out for is for the virus that we spoke about, known as HPV, the human papilloma virus, right? So they look for that in the sample. And if they don't find any HPV, okay, so if you follow me along, I know it looks quite busy with the flow chart, but if you follow me along, we go through the first arrow, no HPV is found. Then you go back to the routine recall, which, as I said, is between 3 to 5 years, depending on the age, okay? Now, if they find that you have HPV, so you have that virus, they then check to see if there are any abnormal cells, okay? Now, if they find that there are no abnormal cells, but you have HPV, you then go back to what's known as the 1-year recall. So they will ask you to come back in a year's time, where then they will check again to see if you still have HPV, because what happens is our bodies are really good, it can get rid of it. So we give you a year to get rid of it. And sometimes no HPV is found when you come back in a year's time, and we put you back to the routine recall every 3 to 5 years. However, sometimes after that 1-year recall, you may still have the HPV there. So we give you another chance, another year for your body to fight against it, right? To see whether or not it's gone. And if it goes away, again, you go back to the normal recall. However, if it persists and it's the 3rd time you've come, even though there are no cell changes at all, you go for what's known as colposcopy. And I'll tell you what that is in a second, okay? Now, the 3rd arrow is where they find HPV and they also find cell changes, so abnormal cells. They send you for colposcopy. So if they find HPV and abnormal cells, you'll always be sent off for colposcopy. And this is a procedure where essentially, I wonder if it's the next slide. Yes. So it's a simple procedure used to look at the cervix under a microscope with a light, all right? It's a 20-minute procedure, and a liquid is applied onto the cervix to highlight these abnormal cells. And what can happen is they either take a biopsy, so that's a little tissue sample of the cervix, or they may do what's known as large loop excision of the transformation zone. So a bit of the cervix where cancer is most common, they take that bit out. Or they'll do something what's known as a cone biopsy. This is where they take essentially a cone-shaped biopsy of the cervix. And that's what it would look like. So you'd be lying on this bed and your legs would be on either side. And this bit is the microscope. Okay. So that's, yeah, so that's it with the results. The other thing to mention about results is sometimes you can have problems. Sometimes it may be that they didn't get enough of the cervical sample, so an adequate sample. Sometimes you may have an active infection or the cervix itself is quite inflamed and irritated. And other times a woman might be on her menstrual cycle. Now, usually you're not supposed to get this done if you're on your period. Okay, and that's because they wouldn't be able to visualize the cells well enough if there's blood. However, some women may be quite close to their period. And unfortunately, as soon as we put the brush in, it leads to bleeding of the cervix. And then unfortunately, they can't look at the sample well enough. So if this happens to any women, this is why, or people with the cervix, this is why then they repeat it in 3 months' time. So if you're ever wondering, oh, you know, I've had it done and they're telling me to do it again in 3 months' time, it's because any of these three things may have happened.
And there are a couple of other things that can affect the results as well. So for example, if you use some jelly on the speculum because people are quite dry down below, it can also affect the results. And also for postmenopausal women who generally their vagina might be more dry and painful to insert the speculum, and that's why you need some jelly on it. And the dryness of the vagina can also affect the sample that is taken. And so for those women, maybe they need a bit of estrogen cream or something for a few months to kind of hydrate the vagina so that they can have a proper sample. So that can happen too. I wonder, Aziza, if you were able to share that photograph of the or the diagram of the cervix, so that we can, for people who have never seen a cervix before, this is what it looks like.
Of course, yes. Okay, bear with me 1 minute. So, all right. So we've been talking about the cervix. So this is what the female reproductive system would look like. And this is around the pelvic area, okay? But if we make it bigger, so if you follow the arrows, these two identical areas are your ovaries. This is the fallopian tube, okay? So that's the bit that usually carries the egg that's made from the ovaries. This whole thing, this area is known as our uterus, okay? Or the womb. This is our vagina, okay? As women. And this is the cervix. So this area here is what we class as the cervix. And that's why we call it the neck of the womb, because essentially it's basically like it's the neck. And this area here, do you remember I said transformation zone? This area here is what's known as the transformation zone. And that basically is unfortunately where cancer most commonly occurs, because the cells of the cervix here is different to the cells here. And that's why it's called transformation, because so it's transforming from this to that. I hope that makes sense.
Great. And actually, Rachel in the chat raised a really good point about the self-test. That one issue with the self-test might be that we're not able to, we miss the opportunity to, as clinicians, to have a look at the cervix, because sometimes the screening may not pick up all the abnormalities 100% of the times, and having that visualization to be able to see the cervix is also important, an important part of the screening test as well.
Absolutely. So the self-HPV screening is a new, it's sort of a new trial that they've started rolling out in the north of London since last month. It is something that is currently being used in different countries, but it's being offered to people who've missed their cervical screening for 6 months. And it's more to try and increase the accessibility to people who find it difficult. And also, yes, it's not it's not as effective as doing a cervical screening. However, having some sort of testing done is better than not having anything at all. So that one doesn't test. It doesn't necessarily, it's not doing what we do with cervical screening. We're not taking any cervical cells. We're just checking to see if the patient has HPV, the human papillomavirus that we said is linked with cervical cancer. So they say that 99.7 to 99.8% of people with cervical cancer have HPV. So if we find that they have HPV, then we refer them for the actual cervical screening so that we could take a look at the cervical cells to see whether or not they're abnormal. But absolutely, Rachel, what you said is so true. If obviously we are not seeing the patient, we lose the opportunity to first to have health discussions in general about their well-being, and maybe they have other concerns. And also we miss the opportunity to look at the cervix, which you don't get that often at all, actually.
Mm-hmm. So, Aziza, what is cervical cancer, and how does it occur?
Okay, so cervical cancer, when we speak about the cervix, like I said, that little area, that tiny area, unfortunately, what happens is you get abnormal cells within the lining of the cervix, which then grow uncontrollably, right? So that happens in any cancer. Now, our body is an intricate system of programming. We have trillions of cells all over our body, and they go through a sequence of events, and they go through the programming to divide in an ordered and organized manner. But sometimes you can have damaged cells, you can have old cells or abnormal cells forming. And when that happens, the body is usually quite good. It picks it up and then it gets rid of it or changes it to make it normal, right? But because of different changes, so it can be genetic, it could be environmental. So if we're smoking or if we're exposed to different chemicals, these sort of things, they can then lead to the abnormal changes, which then leads to the cancer occurring. So these abnormal cells form and they divide, like I say, erratically, and they don't follow the sequence, the normal sequence that the body programs. And then they divide and divide even more. They spread to different areas, unfortunately, and that's what leads to cancer in general. And essentially, that is what happens in cervical cancer. And as I say, unfortunately, it is a cancer that's quite common. It's the fourth most occurring cancer in women. 3,200 women are diagnosed with cancer every single year, and 850 people die of it every single year, unfortunately. Mm-hmm. But it's the most preventable.
We started the chat today on, on the fact that actually cervical cancer is preventable, and 99.8% of cervical cancer is preventable. That is a huge number. So can you talk to us about the risk factors associated with cervical cancer, and what can we do to reduce our risk of getting cervical cancer?
Absolutely. So the first and foremost is attending our cervical screening. As I say, it is known to save 5,000 lives a year in the UK. If we attend our cervical screening, it picks up cancer. Well, it picks up abnormal cells. So these are cells that could potentially develop into cancer. So we're preventing it from occurring because we get rid of these cells if we see them. And then the cancer doesn't develop, essentially. So that's the biggest one, I would say, that we have complete control over, because we can attend to go for these screening tests and reduce the risk of the abnormal cells forming. But then we talk about HPV, the human papillomavirus that I was telling you about. So this is actually a really common virus. 8 out of 10 people will be infected with this virus in their lifetime. Okay. And it's usually harmless, and it's something that our body can fight against. We have hundreds of different types, but the ones that we consider high risk that are associated with cervical cancer, we have 13 different types that are associated with that. Okay. Now, the human papillomavirus is spread through skin-to-skin contact. Okay. And the way that it gets to our cervix is through sexual contact. But I want to emphasize here that when I say that, it doesn't have to be penetrative intercourse. Okay. It could be oral sex or fingering, or using sex toys, that kind of thing. Ones that have been shared between individuals. Those are all ways that you can pick up HPV. Okay. And when we talk about HPV, people most at risk of being infected with it include people who've had intercourse at a younger age, people who have multiple partners or who have had multiple partners, and people who don't use condoms, so barrier contraception, because then again, the skin is directly in contact with the skin. So it increases the risk of picking up the HPV infection. As I say, HPV has this thing where it changes the cells of our cervix, which increases the risk of these cells then becoming cervical cancer. And I know I've said this so many times, but the link between HPV and cervical cancer is just so close. 99.8% of people who have cervical cancer are found to have HPV. So if we can try and change some of our, habits with regards to, if we use condoms and are more, careful with regards to our sexual intimacy, we can then reduce the risk of getting HPV and hopefully then getting infected with HPV. Another risk factor is having other sexually transmitted infections. So there's a link with increase HPV's capability of making the cells abnormal. So again, this is where we encourage condom use as much as possible, because if we can reduce STIs occurring, we can reduce HPV occurring, which then hopefully will reduce the chances of cervical cancer occurring. Another important risk factor, which is a risk factor for so many cancers, is smoking. Every year, 1.5 million people die from cancer that's linked to tobacco, right? And tobacco use is the most important risk factor for cancer, and it's responsible for approximately 22% of cancer deaths. Now, in the case of cervical cancer, 21% of cervical cancer cases in the UK are caused by smoking. And women who smoke are 2 times more likely to be diagnosed with cervical cancer compared to women who don't smoke at all. So there's another thing that I want you to leave here today. It's please, if you do smoke, try and stop. There are so many different services available for smoking cessation. And if you don't smoke, please don't start, because it just causes so many unnecessary deaths, unfortunately. There's no benefit to it. Another risk factor is, this one is a bit controversial because some people then get really worried, but contraceptive pill use for more than 5 years has been found to increase your risk of cervical cancer. However, they do say that once you've stopped using the contraceptive pill, after 5 years, your risk is back to normal as someone who doesn't use a contraceptive pill. And actually, they say 10% of cervical cancer are linked to the pill, and it increases your risk of getting cervical cancer by 2%. 2%, which is small, but it's just something to remember if you are using a contraceptive pill. And another one with regards to lifestyle is obesity or being overweight. So unfortunately, there's a link between estrogen, so sex hormones, and getting cervical cancer, a specific type of cervical cancer that we call adenocarcinoma. And if you're overweight or obese, you produce more of these sex hormones. So then it puts you at more risk. And also, there's been a study that showed that smears, for some odd reason, tend to not be as effective at picking up cancer cells in women who are obese or overweight, or people with a cervix who are overweight or obese. So it's just something to remember. Again, we're trying to lead the healthy lifestyle and trying to maintain a healthy weight, because again, it's linked with cancer, other cervical cancer as well. Other risk factors include having more than 5 live births, which I think it's to do with the changes, the hormonal changes and what it does to the cervix. So if you've had more than 5 children, it increases your risk. And being immunocompromised. So when I say this, and please forgive me if I'm going quite basic to the audience, but I just don't know what level I'm pitching at. But immunocompromised just means that your immune system is essentially compromised. You're not able to fight off infection as well. And this can be due to an infection, so HIV, the human immunodeficiency virus, or it could be because of medications that you're taking. So you could be on steroids, you could be on something called azathioprine. Those sort of things will affect your body's ability, their immune system. And if you think about it, as I say, HPV is a virus which causes an infection. So if your immune system is compromised, how are you going to fight against it? So you're more likely then to have the cervical changes occurring. And then this is more for older women. So between the 1940s and 70s, there was a medication known as DES, which they gave to pregnant women to try and reduce their chances of having miscarriages or preterm labor, right? And unfortunately, they later found that women who were born to these women, those pregnant women who took those medications, they are at higher risk of developing cervical cancer by 2.2 times. So that's another risk factor. And then things that we have no control over are family history. Unfortunately, if you have a first-degree relative, so that would be a close relative, so either your mom, your sibling, or your children, your daughter, if they've had cervical cancer, that increases your risk of developing cervical cancer. And unlike majority of cancers, unfortunately, cervical cancer is actually much, much more common in younger people. So people under the age of 45. And that group are the ones who don't attend as much, unfortunately. Now, the reason is, so they say 50% of cervical cancer cases in the UK are diagnosed in women under the age of 45. More than 50% are diagnosed in women under the age of 45. And it's more common because, there's not much understanding as to why, but basically women under the age of 45 are more likely to have the high risk HPV, so the HPV that are associated with cervical cancer. And that's why they're more likely. And if you've had a previous cancer to your kidneys or your vagina, your vulva, your urinary tract, that increases your chances of having it in your cervix as well. And unfortunately, women in lower socioeconomic countries, they're much, much more likely to have cervical cancer. 85% of the cervical cancer in the world occurs in women of this group. And it's in part to do with, again, awareness, understanding, accessibility, affordability. But there are risk factors that we can control and we can change within our lifestyle to make a difference.
Things that we can change include going to screening regularly and respond to your invitation when you get an invitation to go to your screening, because the screening, again, is not designed to pick up cancer, but to pick up any pre-cancer changes and this HPV virus, which can be treated. And as Aziza said, HPV can be cleared by the body itself. It might take a few months, but we have very good immune systems, and it can do its job clearing the virus out. But a couple of things might reduce our ability to clear that virus, and that would be if you were immunocompromised, and also if you are smoking, because smoking can affect the ability of the body to clear some of these abnormal cells, that once you stop smoking, the the chances of this HPV causing changes that lead to cancer is much reduced. And actually having HPV is not the end of the world. As Aziza said, it is really common. And if you have HPV, it doesn't mean that you will get cancer, because the body can clear it. And also that another thing that we can do is living a healthy lifestyle and maintaining a healthy weight. These are some of the things that we can actively do to help prevent cervical cancer.
Yeah, amazing. I actually had a question directed at me directly. It just said, how long does it take to perform the smear test? Is it done within minutes or seconds? Honestly, genuinely, the actual procedure itself, if the cervix is easy to find, like literally seconds. The procedure where they're, using the brush, so putting the speculum in and then using the brush. If they find your cervix quite quickly, that's it, maximum a minute or two, if that. Sometimes, like I say, the cervix can be a bit deep or a little bit difficult to find. The nurse or the clinician will have you do certain maneuvers. They may have you sit on your fists, and that would help to sort of bring your pelvis up a little bit, so then the cervix becomes more visible. Or they then may need to use the longer speculum. So they would have used the regular one first, and then they take it out and put the longer one in order to find the cervix. But that's not common at all. In majority of the cases, minutes, if that. The process that takes long is you talking to the clinician through what the procedure entails and getting dressed and undressed and that sort of thing, but it shouldn't last too long.
When we talk about prevention, we must talk about the vaccine as well. What is the vaccine and how does it work?
Absolutely. So I have a slide on this that I would like to share. So it's very important to talk about the vaccine, as you say, because of the link that we know that we have between HPV and cervical cancer, more than 99% linked with cervical cancer. So the vaccine works by protecting against HPV infection. Okay, so what it does is it prepares your body, basically arms your body with what's called antibodies, essentially, against HPV. So you don't get infected. If you get exposed to the virus, you don't get infected, right? But this needs to be done at an earlier age. So it's in the UK, it's offered to girls and boys between the ages 12 and 13. Now, girls have been offered it since 2008, okay? But boys, they only started doing it in 2019 because they realized actually it's important that we vaccinate both boys and girls, because boys can infect the girls with HPV and vice versa. Now, it's done in 2 doses, okay? So they get the first dose between the ages of 12 and 13, and then they get the second dose anytime between 6 and 24 months from when they get the first dose. But it's really important that they have both doses in order for this vaccine to be effective, okay? Now, it has proven to be effective, and it has proven to reduce the chances of cervical cancer. Now, there was a study that was published in the New England Journal of Medicine only last year, end of last year, October, where essentially they concluded that the risk of cervical cancer by the age of 30 was 63% lower in vaccinated women compared to unvaccinated women. So the way that this study ran is they literally did this over a span of 11 years. They followed 1.5 million Swedish girls and women between the ages of 10 and 30, and they assessed their cervical cells, so on and so forth. So if they were diagnosed with cervical cancer, and they found that actually cervical cancer by the age of 30 was 63% lower in women who were vaccinated. So it is quite effective at reducing the recurrence or the occurrence of cervical cancer. And that's why it's important to get it. And also, sorry, just to mention as well, women under the age of 25 in the UK who haven't had the vaccine can be offered it if they contact their GP to have the vaccine. So women under the age of 25 can have the vaccine on the NHS if they've never had it.
And just a note to say to the younger audience is that if you have had the vaccine, it doesn't mean that you don't need to go to screening. It is still important that you do get screening, because although a huge, percentage of cervical cancer is due to the HPV virus, that there is still a small number that could be due to other causes, and it's still important to get the screening. So having the vaccine is important, and even after the vaccine, having the screening is still important on a regular basis.
Absolutely.
And Irene just asked if the cervical screening have any side effects, Aziza.
Yeah, I don't know that it does, to be honest. As I say, all they do is they insert the speculum and this brush, and both of them are sealed in a sterile bag, essentially. So it's unlikely that we can introduce an infection into you. So with regards to screening, the actual procedure, the smear that we do, smear test, I don't know that it causes any complications. I mean, as I say, it can be a bit uncomfortable for some people, and it can lead to maybe a little bit of bleeding, because again, we're sort of grazing a bit of the cervix, but have not heard of any complications. But thank you for asking. And thank you to everyone who's sharing their stories on the chat. Agnes, it's great.
Ulrich just mentioned a paper here. Ulrich, if you're there, would you be interested to come on just to share this paper?
I haven't fully digested it either, but it's quite interesting data to see that there's quite a few mechanisms how antioxidants can help with stopping tumor progression and of viral clearance. And I think it's quite important to see that there's certain substances like EGCG, this epigallocatechin gallate, and which is in green tea and even more concentrated in matcha tea. There's also capsules one can get with concentrated stuff like that. And there's quite interesting studies coming out of that working group who developed these, which is interesting. And I must say that for some patients, I recommend these now. But we have some patients in the colposcopy clinic who just can't shift this virus. It's in the colposcopy clinic, and you probably, Aziza, have seen them as well. They come back and back and back, and they have a low-grade smear, and sometimes they end up with a LEDS treatment, and you do another LEDS treatment, and the virus is still there, and they still have abnormal cells. And so one route is to recommend them either complete diet change if they're motivated, or a strong antioxidant supplement like this one, or even encourage them just to drink more green tea and matcha tea, if they want it on a low cost basis, But I think there's probably more exciting things coming from that area. And of course, vitamin D is very important to mention in that context as well. The vitamin D is very important for the immune response, as we learned in the previous seminaries here. And just to use that opportunity of screening as well to remind people that in the Northern Hemisphere, we really need to be on vitamin D, and that's across all skin colors. So that's very, very important to use that opportunity. Yeah, that's basically the other thing is, I don't know, Aziza, how you feel about vaccinating people who already have the virus.
Well, it's a good question. I think at the moment they're trying to roll. Well,
I haven't fully digested it either, but it's quite interesting data to see that there's quite a few mechanisms how antioxidants can help with stopping tumor progression and of viral clearance. And I think it's quite important to see that there's certain substances like EGCG, this epigallocatechin gallate, and which is in green tea and even more concentrated in matcha tea. There's also capsules one can get with concentrated stuff like that. And there's quite interesting studies coming out of that working group who developed these, which is interesting. And I must say that for some patients, I recommend these now. But we have some patients in the colposcopy clinic who just can't shift this virus. Where it's in the hospital, and you probably, Aziza, have seen them as well. You know, they come back and back and back, and they have a low-grade smear, and sometimes they end up with a LETS treatment, and you do another LETS treatment, and the virus is still there, and they still have abnormal cells. And so one route is sort of to recommend them either complete diet change if they're motivated, or a strong antioxidant supplement like so this one, or even encourage them just to drink more green tea and matcha tea, you know, if they want it on a low cost basis, you know. But I think there's probably more exciting things coming from that area. And of course, vitamin D is very important to mention in that context as well. The vitamin D is very important for the immune response, as we learned in the previous seminaries here. And just to sort of use that opportunity of screening as well to remind people that in the Northern Hemisphere, we really need to be on vitamin D, and that's across all skin colors, you know. So that's very, very important to sort of use that opportunity. Yeah, that's basically sort of, the other thing is, I don't know, Aziza, how you feel about vaccinating people who already have the virus.
Well, it's a good question. I think at the moment they're trying to they're encouraging more and more homosexual men to have the vaccine as well, because of the link between HPV and anal cancer and throat cancer and so on and so forth. You know, the way the mechanics work, I think they say that it's more effective, isn't it, if the patient has never been exposed to the virus.
Of course.
Right.
Of course.
So I guess part of the reason that they're encouraging it is, I mean, and it's a study that I guess is still being run, is whether or not maybe even after having been exposed, having the vaccine could potentially give them a bit further protection, more immunity.
Exactly. Yeah.
I'm not sure. I think it's a study that they're still trying to ascertain whether or not there's a link. The HPV vaccine study, that one took 11 years before they, you know, finally released the results.
Well, that's right. And I must say, I have a very low threshold to recommend my patients on the colposcopy clinic to get the vaccine, particularly that group which I mentioned earlier, which just can't seem to shift the virus, or indeed those who did need a LETS treatment. And there does seem to be data coming through that the risk of recurrence after LETS is less if you are vaccinated. Mm-hmm. So LETS, for those who may have difficulty, did you mention LETS earlier in your talk? You did.
I did, but you can elaborate on what it is, by all means, please.
It's just sort of the next step in the patient journey. You know, once you have an abnormal smear and it's confirmed that there may be corresponding atypical cells or abnormal cells, then you would offer removal of a tiny patch of skin on the cervix. And that's mostly done now with a little electric wire loop. And we try to remove as little tissue as possible. But the sad thing with this treatment is that it doesn't cure the virus. And I think that's very important for the patient to understand that. We are only treating the cells, as I always put it, which have been upset by the virus, but that's about it. The virus is still there. And you may be lucky that the immune response you get from just causing this little injury may clear the virus, but that's not always the case. No. And you see them back. And that's where the vaccine, I think, has some role to play to sort of help the body to sort of clear that. And that's where maybe these strong antioxidants, another one would be, for example, pomegranate would be very strong in antioxidants and stuff like that. So one could recommend these sort of foods. And definitely one would sort of discourage foods which are upsetting our immune system, such as sort of artificial sweeteners, sweetened beverages, and animal products in general.
And Ulrich, you mentioned a really good point in the chat, actually, about the HPV vaccine. It doesn't cover all of the HPV strains that could cause cervical cancer. So that is another important point for people who have had the vaccine, or know people who have had the vaccine and think that they don't need to.
I haven't sort of fully sort of digested it either, but it's quite interesting data to see that there's quite a few mechanisms how antioxidants can help with stopping tumor progression and of viral clearance. And I think it's quite important to sort of to see that there's certain substances like EGCG, this epigallocatechin gallate, and which is in green tea and even more concentrated in matcha tea. There's also capsules one can get with concentrated stuff like that. And there's quite interesting studies coming out of that working group who sort of developed these, which is interesting. And I must say that for some patients, I recommend these now. But we have some patients in the colposcopy clinic who just can't shift this virus. It's in the colposcopy clinic, and you probably, Aziza, have seen them as well. They come back and back and back, and they have a low-grade smear, and sometimes they end up with a LEDS treatment, and you do another LEDS treatment, and the virus is still there, and they still have abnormal cells. And so one route is sort of to recommend them either complete diet change if they're motivated, and a strong antioxidant supplement like so this one, or even encourage them just to drink more green tea and matcha tea, if they want it on a low cost basis, But I think there's probably more exciting things coming from that area. And of course, vitamin D is very important to mention in that context as well. The vitamin D is very important for the immune response, as we learned in the previous seminaries here. And just to sort of use that opportunity of screening as well to remind people that in the Northern Hemisphere, we really need to be on vitamin D, and that's across all skin colors, So that's very, very important to sort of use that opportunity. Yeah, that's basically sort of, the other thing is, I don't know, Aziza, how you feel about vaccinating people who already have the virus.
Well, it's a good question. I think at the moment they're trying to they're encouraging more and more homosexual men to have the vaccine as well, because of the link between HPV and anal cancer and throat cancer and so on and so forth. The way the mechanics work, I think they say that it's more effective, isn't it, if the patient has never been exposed to the virus.
Of course.
Right?
Of course.
So I guess part of the reason that they're encouraging it is, and it's a study that I guess is still being run, is whether or not maybe even after having been exposed, having the vaccine could potentially give them a bit further protection, more immunity.
Exactly, yeah.
I'm not sure. I think it's a study that they're still trying to ascertain whether or not there's a link. The HPV vaccine study, that one took 11 years before they, finally released the results.
Well, that's right. And I must say I have a very low threshold to recommend my patients on the colposcopy clinic to get the vaccine, particularly that group which I mentioned earlier, which just can't seem to shift the virus, or indeed those who did need a LEDS treatment. And there does seem to be data coming through that the risk of recurrence after LEDS is less if you are vaccinated. And so LEDS, for those who may have difficulty, did you mention LEDS earlier in your talk? You did.
I did, but you can elaborate on what it is, by all means, please.
It's just sort of the next step in the patient journey. Once you have an abnormal smear and it's confirmed that there may be corresponding atypical cells or abnormal cells, then you would offer removal of a tiny patch of skin on the cervix. And that's mostly done now with a little electric wire loop. And we try to remove as little tissue as possible. But the sad thing with this treatment is that it doesn't cure the virus. And I think that's very important for the patient to understand that. We are only treating the cells, as I always put it, which have been upset by the virus, but that's about it. The virus is still there. And you may be lucky that the immune response you get from just causing this little injury may clear the virus, but that's not always the case. No. And you see them back. And that's where the vaccine, I think, has some role to play to sort of help the body to sort of clear that. And that's where maybe these strong antioxidants, another one would be, for example, pomegranate would be very strong in antioxidants and stuff like that. So one could recommend these sort of foods. And definitely one would sort of discourage foods which are upsetting our immune system, such as sort of artificial sweeteners, sweetened beverages, and animal products in general.
And Ulrich, you mentioned a really good point in the chat, actually, about the HPV vaccine. It doesn't cover all of the HPV strains that could cause cervical cancer. So that is another important point for people who have had the vaccine, or know people who have had the vaccine and think that they don't need to go to screening. Because of this, it is really important that they do go for the screening.
Absolutely. And as I say, I'm now seeing the first cohort coming through the colposcopy clinic who have had the bivalent vaccines. And it's very disheartening to see these women to come through, because they are rightly so expected to be protected, but they're not really. And the future study we run is the first papers from the first studies coming out had unfortunately even had already alluded to that incidence of CRN3 is only reduced by 23% overall in that group. So it's not that a dramatic reduction in that first cohort with the bivalent vaccines really. And hopefully with the non-valent vaccines, we may see a further reduction. But so I would always actually recommend people who have been caught out having had the bivalent vaccine to get the non-valent vaccine now on top of that. The only unfortunate thing is they have to pay very heavily for that 600. It sets them back, it's quite a lot.
Go to screening because of this. It is really important that they do go for the screening.
Absolutely. And as I say, I'm now seeing the first cohort coming through the Convosby Clinic who have had the bivalent vaccines. And it's very disheartening to see these women to come through because they are rightly so expected to be protected, but they're not really. And the future study we run is the first papers from the first studies coming out had unfortunately even had already alluded to that incidence of CRN3 is only reduced by 23% overall in that group. So it's not that a dramatic reduction in that first cohort with the bivalent vaccines really. And hopefully with the non-valent vaccines, we may see a further reduction. But so I would always actually recommend people who have been caught out having had the bivalent vaccine to get the non-valent vaccine now on top of that. The only unfortunate thing is they have to pay very heavily for that 600. It sets them back, it's quite a lot.
They're encouraging more and more homosexual men to have the vaccine as well because of the link between HPV and anal cancer and throat cancer and so on and so forth. The way the mechanics work, I think they say that it's more effective, isn't it, if the patient has never been exposed to the virus,
of course.
Right?
Of course.
So I guess part of the reason that they're encouraging it is, and it's a study that I guess is still being run, is whether or not maybe even after having been exposed, having the vaccine could potentially give them a bit further protection, more immunity.
Exactly, yeah.
I'm not sure. I think it's a study that they're still trying to ascertain whether or not there's a link. The HPV vaccine study, that one took 11 years before they, finally released the results.
Well, that's right. And I must say I have a very low threshold to recommend my patients on the Convosby Clinic to get the vaccine, particularly that group which I mentioned earlier, which just can't seem to shift the virus, or indeed those who did need a LETS treatment. And there does seem to be data coming through that the risk of recurrence after LETS is less if you are vaccinated. And so LETS, for those who may have difficulty, did you mention LETS earlier in your talk? You did.
I did, but you can elaborate on what it is, by all means, please.
It's just sort of the next step in the patient journey. Once you have an abnormal smear and it's confirmed that there may be corresponding atypical cells or abnormal cells, then you would offer removal of a tiny patch of skin on the cervix. And that's mostly done now with a little electric wire loop. And we try to remove as little tissue as possible. But the sad thing with this treatment is that it doesn't cure the virus. And I think that's very important for the patient to understand that. We are only treating the cells, as I always put it, which have been upset by the virus, but that's about it. The virus is still there. And you may be lucky that the immune response you get from just causing this little injury may clear the virus, but that's not always the case. And you see them back. And that's where the vaccine, I think, has some role to play to sort of help the body to sort of clear that. And that's where maybe these strong antioxidants, another one would be, for example, pomegranate would be very strong in antioxidants and stuff like that. So one could recommend these sort of foods. And definitely one would sort of discourage foods which are upsetting our immune system, such as sort of artificial sweeteners, sweetened beverages, and animal products in general.
And Ulrich, you mentioned a really good point in the chat actually about the HPV vaccine. It doesn't cover all of the HPV strains that could cause cervical cancer. So that is another important point for people who have had the vaccine or know people who have had the vaccine and think that they don't need to go to screening. Because of this, it is really important that they do go for the screening.
Absolutely. And as I say, I'm now seeing the first cohort coming through the Convosby Clinic who have had the bivalent vaccines. And it's very disheartening to see these women to come through because they are rightly so expected to be protected, but they're not really. And the future study we run is the first papers from the first studies coming out had unfortunately even had already alluded to that incidence of CRN3 is only reduced by 23% overall in that group. So it's not that a dramatic reduction in that first cohort with the bivalent vaccines really. And hopefully with the non-valent vaccines, we may see a further reduction. But so I would always actually recommend people who have been caught out having had the bivalent vaccine to get the non-valent vaccine now on top of that. The only unfortunate thing is they have to pay very heavily for that 600 and sets them back. You know, it's quite a lot.
So it's Gardasil at the moment, isn't it? That's the quadrivalent vaccine that's being offered to the 12 to 13-year-olds. So that's the one that covers your HPV 16 and 18 as well as 6 and 10. That's the one that the 12 and 13-year-olds have been offered. Is that as far as
here in Ireland, they get Gardasil 9 now, which covers 9 of the high-risk viruses.
Yes, yeah, that's the non-valent that you were talking about, yeah.
Exactly. They often get that offer now, and unfortunately, they are still the old one, as you correctly say, in the pharmacies.
Yeah.
And I had a very unfortunate communication from a pharmacist the other day, where he, in error, despite my clear prescription, had given out the quadrivalent vaccine. And I obviously wanted him to give the monovalent vaccine to the patient.
Because the names are too similar. That's the problem.
The names are too similar.
Yeah.
Exactly. And I think that's very important. The one is very clear on the prescription. That's why I always put the number there and write out the word and underline it and say to the patient, ask for the 9 one, the new one. You know, don't get the old one. Yeah, no, it can give a false sense of security. That's the unfortunate thing. Yeah. Yeah, for the boys, it's quite important to actually be vaccinated too, because they obviously get a very nasty form of head, neck, and throat cancer from it. And obviously with sexual practices, they can easily get into nasopharynx. So that cancer has actually a worse prognosis. So it is important from that point. But there was also a question earlier about side effect of screening.
Yeah.
And I think the important side effect of screening is overdiagnosis, or better say false positives. That's the important side effect. And very correctly there, I think Rachel was it said that the age limit is 25. And indeed with HPV screening now, there was a very serious consideration, should we actually lift it to 30? Because obviously when you have your coitarchy at sort of whatever age that may be, you're HPV positive naturally for quite a while. And if you get screened during that natural phase of natural positivity, you will be subjected to assessments which may lead to treatments, which may lead to harm. So therefore, it may have been more prudent to actually only offer screening from 30 years on, rather than from 25. Because you don't want these young women coming in. Unfortunately, I see, and you probably see it as well, Aziza, a large group of younger women where the mothers were so concerned that they didn't give the vaccine, but then they sent them for a private smear test at age of 20, when they're of course HPV positive. And then you see these completely frightened young women who then obviously will have HPV, will have CRN1 because they are just HPV positive. And then you have them in the colposcopy clinic for the next 5 years.
Yeah, it would have been fine otherwise, which then leads to trauma, and they don't want to attend screening anymore. Do you understand? It has long-term effects. But that's a very good point, actually, that I should have mentioned.
The trauma is a big point, and thank you for mentioning that. I think we cannot underestimate how huge that is, particularly these women who maybe just have intercourse once, you know, and then they immediately push to the GP by their mothers who are worried because they had intercourse, they have to have a smear test straight away. And then these poor women come completely frightened to the clinic. They're absolutely terrified. They're convinced they have cancer. And then, as I say, you have to keep sending them back because they still have these abnormal cells, and you try to protect them from any treatment. But just by seeing them, you make them so nervous and you scare them so much, you know. So there's huge implications. And I think there's that is a big harm of the screening.
So how can we balance that?
By educating the mothers of these young women that they should vaccinate them and not send them to private smear tests. You know,
I think
then,
what's also really important is making sure people are aware of symptoms as well to look out for. Yes, we 100% encourage, and the whole point is to encourage people to attend screening. Please don't be put off by the last couple of minutes of what we've just said. But the whole point is to encourage you all to attend screening, but also to be aware of symptoms to look out for. So even if you're under 25, and we've said that the risk of cervical cancer is much lower, doesn't necessarily mean that you cannot get cancer under the age of 25. It does happen, though it's rare. And that's why it's important to be aware of symptoms to look out for. And those include having unusual bleeding. So that's if you're bleeding at odd times when it shouldn't, when you're not due your period, or if you have bleeding during or after intercourse, or if you've, so for older women, if you've gone past menopause and you've stopped bleeding completely, and then all of a sudden you've started bleeding, then those are warning signs. Also, if you notice that there's like a really foul smelling vaginal discharge, or if you have pain across your hips and sort of your pelvic area that's just not going away, these sort of things, you then go to your GP to get assessed. And if they examine the cervix and they're concerned, they then refer you to the 2-week wait clinic, where most likely you'll see someone like Ulrich, and you'll have a speculum, and they'll do some further investigations to find out whether or not you do have cervical cancer. But it's just something to remember. And another important point, again, going with screening, is unfortunately cervical cancer in the early stages, majority of people do not have any symptoms at all. Okay. And this is why we encourage you to go for screening, because you can pick up, as I say, abnormal cells, which could potentially progress to cancer, or you can actually pick up early cancer cells. So again, the treatment would hopefully be less invasive, and your prognosis, so your survival chances, will be much higher.
This is a brilliant discussion, and not only for cervical cancer, but for everything that we do. And I like to stress this for our patients. I love that this was brought up, that there are always this is all about information and the combination of the clinical findings with the findings of a test, and through open dialogue which allows us to come to a conclusion which is best for the patient, and that can only happen through these open conversations that we're having now on Afternoon Tea. And it's good to bring up these clashing ideas sometimes, because it will only allow us to understand the problem a little bit better. So yeah, that's fantastic.
It's a tricky thing with symptoms with cervical cancer, because first the clinical symptoms. So what is the symptom? Is it once after intercourse you had a bleed? Is it twice? Is it a heavy bleed? Is it a light bleed? And it depends entirely on who the patient sees and how nervous the patient is. And often it's a vicious circle, because the more nervous the patient is, the more likely is that the period will be irregular because of the stress hormone she's releasing. Then she have more bleeding in between her periods, and there's more bleeding after intercourse. And it can be very quickly a vicious cycle. And then we have in Ireland, I don't know if you have it in the UK, on the cervical screening form, you have a box the GP can tick, or the practice nurse, suspicious cervix, which is a nasty little box, because if the GP is really worried about cancer, he or she should ring me and say, listen, Ulrich, I think this lady has cancer. Will you see her in 2 weeks? And I will, of course, no problem. Right. But just to tick this box is a bit of a nasty thing, because it automatically means the patient has to come to colposcopy, even if her screening test is normal. And then often the GP doesn't have to declare anything. So these are a bit of the faults in the screening problem rationale, where we get a lot of very anxious women coming in, where they have very minor symptoms, which in itself, it's very hard to judge if there's anything to it.
Absolutely, yeah. It's trying to figure out, but it's also trying not to dismiss the symptoms. But like you say, like Linda said as well, this is where you go to the clinician, and then they use their clinical acumen and take more of a history to ascertain exactly what you mean. Because as you say, Ulrich, sometimes people may bleed, again, depending, are they on some sort of hormonal contraceptive, which could be, attributing to this abnormal bleeding, and so on and so forth. So it's a whole picture, but it's just remembering, this is where it's so important to know your normal as an individual. Okay, what is normal for you? What does your body do? normally, and what has it always done? If you start to notice new changes that weren't there before, you never had any of these experiences ever, and you're getting them, then you should be concerned, and you should see your GP for reassurance or for guidance as to whether or not you need further investigations or whether you need to be referred. So that's where I would encourage everyone to know your normal, know what's normal, not just with regards to vaginal bleeding and that sort of thing, everything, you know, what are your stools like? what is it like? Yeah. How often do you go, you know, to open your bowels? What does your urine look like? What's normal? What is your normal? You know, and if you know what's normal for you, and breast examination, this is where I'm always like, make sure that you examine your breast, know what's normal for you, because then you can pick up really quickly when something is abnormal, and you won't be, you know, you won't be always picking up, oh my God, this is abnormal, this is abnormal. If you've known what's normal for you, you won't constantly be anxious. And just because someone else says, oh, I get this, and you don't get it, doesn't mean that there's something wrong with you, if that's always been the case for you, you know, for as long as you know. The other thing okay.
Sorry, this is just such a good point here. I want to pause and just think about it, because this is where I like to stress it to my junior doctors that I didn't find anything on examination, but the parents are really worried, or the patient is really worried still. So I always stress that the patient knows best. If you didn't find something within 10 minutes examination, but the patient is really worried, we need to go further. We need to ask more. We need to find out what's going on, and listening to that patient often helped me find things that I didn't find on the first clinical examination within 10 minutes, or reviewing their current laboratory tests were normal, their observations were normal, the patient looked well, but they were complaining that things have changed. And I love that you brought that up, because we need to listen to the patient, and we need to empower them even more than ever right now, when we are really short of time, to share their normal, to know their bodies, and to encourage them, and not remove that power from them, but give it back to them, to say, I'm here, I'm listening to you. You know your body best. Tell me what has changed, and we'll start from there. And maybe right now we won't find anything, but we'll make sure that we'll investigate further to see what it is.
And remember, nobody knows you better than you. You are your own expert. So nobody else is an expert on you. So just knowing your normal, knowing what is normal for you, it's so important, as we have emphasized multiple times now.
Absolutely. But it's just so important to re-empower our patients, I think, because in our current system, we are removing them by trying to tell them what you should do, what you shouldn't do, what you're feeling. Sometimes we are going so far as to make our patients feel that, no, you're not feeling that way. But, well, I am feeling that way, but no, you're not. I mean, this conversation has happened, and I really want to step it out as much as possible, that we listen to our patients with new ears.
If you find something that you're, not happy about, and you think something is abnormal for you, and you go to one clinician, one doctor, and they're not listening, remember that you have a valid point if you have found something abnormal, and don't let that one clinician put you off, and do, seek a second opinion. And it is within your right to seek a second opinion. And we don't have to get offended about it, because sometimes other people have expertise that we don't have.
Sometimes it does help to go in with completely new eyes. As a clinician, if you have done all the investigations and the patient keeps coming and they're really concerned, and it might be actually, if they see someone else completely brand new, they may go down a route that you wouldn't have even considered. So
I would say a very important point, which I've learned the hard way again and again, is the answer is not always doing more tests. Yes, the patient feels that she's not listened to. Yes, the patient feels that something is amiss, but that's not necessarily anything you find with another test. Mm-hmm. And I sort of started a habit of asking a particular question now, which is, tell you, remember when you last time didn't have this problem? Let's go back 5 months. Did you have it then? Maybe I did. Okay, let's go back 5 years. And then, okay, I didn't have it 5 years ago. So let's walk forward. What happened? And I get amazing results. That suddenly it turns out dad got colon cancer. Since then, she has abdominal bloating and pain. Since then, her bowel habits have changed, right? And so on and so on, right? And I could have done another 10 colonoscopies and CTs and whatever, and I would probably have found 3 incidentalomas and have done 5 operations for those without any benefit. But actually leading her that way to say, okay, that's when actually all these symptoms started, when I was starting getting worried about my dad. Would he die? Would he make it? All these sort of things. And then having these functional pains there. So I think that's important to sort of acknowledge that body and mind do work hand in hand. Yeah. And the body will give us symptoms for the organ of our concern. In this point, her bowel was the concern because she was afraid that she would have bowel cancer herself, her dad had bowel cancer, and so on and so on. And then leading her to sort of this aspect, then actually say, okay, then actually sort of makes a click and makes the connection. You don't have to say anything more then. It all falls into falls together. Whereas I see many patients who have been from Pontius to Pilate. They've had all the possible MRIs. I've had patients who have weekly ultrasound scans for some pains and stuff like that until they finally come. But nobody ever asked the right question.
This is very important, where the whole patient is looked at.
A question from someone who asked me directly. They said, when you talked about the increased risk with the contraceptive pill, does that apply to other hormonal treatments such as the hormone releasing coils and the hormone patches? Thank you. As far as I'm aware, and I'll have Ulrich correct me in case, it is a contraceptive pill. So it's a combined pill, and it's the estrogen aspect that increases the risk of the cervical cancer. So no, it's not, as far as I'm aware, the link is more so with the contraceptive pill and not with the other hormonal treatment, because the other hormonal treatment are progesterone only. So that's the hormone that they use. And it's the estrogen often that's associated with the adenocarcinoma type of cancer associated with cervical cancer. But Ulrich can...
Yeah, I don't know. With adenocarcinoma, yes, I would give you that one. With the squamous cell carcinomas, I'm not so sure. Because the squamous is obviously more related to the virus, and you could argue, well, obviously a woman who uses a contraception doesn't want to get pregnant, so she may be still on the dating circle, she may have a higher exposure to the HPV virus, whereas a woman who doesn't need contraceptions, obviously in a relationship and wants to get pregnant. So maybe that's a confounder.
She's curious to know whether the hormonal element within taking those type of contraception is linked. And as far as I'm aware, from Cancer Research UK, they only linked it with the contraceptive pill. But that's a really good point, actually, what you just said with regards to if they're using contraception, are they on long term? That's a really good point. But as far as I'm aware, it is the contraceptive pill that's associated. And
that's right. Yeah, but I wonder, is it exposure to the virus rather than the element, the pill itself? I'm not defending the pill, and I'm not a great friend of it either, I must admit. And we see loads of other side effects. But with HPV, I can't really see that connection from a biological point of view, how it should work. But maybe somebody has the answer, but I don't.
I have a question, actually. So we talked about HIV and immunosuppression. In this screening, so dependent on your age group, 25 to 49, you're screened every 3 years, and 50 to 64, you're screened every 5 years. With HIV, do you get screened every year?
Renal transplant recipients, they get screened every year.
Okay.
On immunosuppressants, yeah, they get screened every year. And HIV, yes, you get screened every year as well. And obviously they have a very high chance of minor cytological abnormalities, but highly active antiretroviral therapy actually kills the HPV as well as the HIV.
So we have learned quite a lot. I have learned quite a lot from a patient point of view. I'm definitely getting my cervical smear screening done this year. So thanks, guys. Aziza, would you be able to summarize in 3 points what would you like your patients to know and to take away from this talk?
Absolutely. So Thank you so much, everyone who's tuned in, and thank you for this opportunity. My 3 take-home would be, the first one, as we've already emphasized a few times: know what's normal for you. Know what's normal for you, and know your body. The second would be, please, please, please attend your cervical screening. Well, all of your screening appointments, if possible, because the whole point is to try to pick things up early, to try and prevent the cancers from occurring at all, and or at least reduce the progression and improve the prognosis. And the final thing is, this is all about lifestyle medicine, isn't it? So, and we know that there is a link. And in fact, they say that a third, I'm going to read the quote out, around 1/3 of deaths from cancer are due to the 5 leading behavioral and dietary risks: high body mass index, so being obese or overweight, low fruit and vegetable intake, lack of physical activity, tobacco use, and alcohol use. So if we can try and adapt these 5 behavioral and lifestyle factors, we can reduce the risk of us developing cancer, because there's a link. 1/3 of cancers are linked with these things. So those are my 3 take-homes.
Great, thank you, Aziza. And just a reminder as well that even though we're, still in the pandemic lockdown, like the cervical cancer screening is still ongoing. So don't let that put you off from contacting your GP. If you think that you're due or overdue for your screening, still, telephone, book your appointment for screening, because the screening clinics are still running. And if you're unsure, just ring and ask.
Absolutely. And after this, we are going to stay for 15-20 minutes, which will not be recorded or streamed, so that we can actually talk to you about screening if you have any more private burning questions. So you can connect with us on Afternoon Tea with Docs on YouTube, Instagram, and on Facebook. And now that we learned how to live stream our events every single Sunday, you will be able to watch these educational videos on all of these platforms, including Instagram. So thank you so much for joining us today. Thank you, Dr. Sesay, for joining us. And if you want to connect with Dr. Sesay, she's doing incredible videos herself on Instagram as well. And this is now on YouTube too. So if you haven't caught her live, you can watch all of Talks with Dr. Sesay on Instagram and on YouTube.